speaker, Dr. Clint McKinney. Dr. McKinney has worked in healthcare for over 30 years, the first 14 years as a rural family physician practicing the full scope of family medicine. He has both owned a private practice and worked with large healthcare systems. Currently, Dr. McKinney works as a part-time emergency department physician in rural Minnesota. Dr. McKinney is a clinical associate professor and deputy director in the Department of Healthcare Management and Policy at the University of Iowa College of Public Health. He also is a member of the Rural Policy Research Institute. Prior to his position at the University of Iowa, Dr. McKinney worked with nearly 50 rural providers and communities as a healthcare consultant. Dr. McKinney has served the national committees for the Institute of Medicine, the Department of Health and Human Services, the American Academy of Family Physicians, and the American Medical Association. In his capacity as a rural health advocate, Dr. McKinney writes and presents nationally. Now I will turn it over to Dr. McKinney.
Hello, everyone. And Kim, thank you very much for that introduction. It's a little much. I kind of think of myself professionally more as a primary care doc, and in fact, just as soon as we finish this webinar, I'm off to work in the emergency room Friday afternoons and Friday nights in the ER. Oh joy. Well, anyway, we want to get started here on a subject that's very near and dear to me. I've really been lucky to work on both sides of the physician-administrator fence, and I know how tenuous sometimes straddling that fence can be for each party. So I'm hoping I might be able to add a little bit of insights from my perspective about how administrators can straddle that fence more successfully. Let me start here first by kind of reminding folks that medicine is a profession, and classically it's one of the four professions that include medicine, law, the clergy, and professional military officers. And of course, through the ages, there's been lots and lots of us, starting with Hippocrates as kind of the founder of medicine. And I'm not sure we've really lived up to all of these all of these ideals. I think the Institute of Medicine has taught us that we're not always good at first doing no harm. And I don't think very many of us are as wholesome as Marcus Welby, and quite frankly, we're just not as dreamy as Dr. McDreamy. But nonetheless, these are the folks that we are working with. And we're working in a landscape right now that has four, I think, main converging forces that are impacting all of us in medicine: physicians, non-physician providers, hospitals, nurses, et cetera. One is the price reduction threats and volume reduction pressures. You all know this. You hear from your PPS hospital colleagues about readmission penalties. That's a volume reduction pressure. You've probably gone to negotiate with your third-party payers, and you're finding price reduction threats as well, too. We're also seeing more quality of care measures and accountabilities. Quite frankly, I'm in favor of this. I wish it were the case that we do good work because that's our culture and our calling, but the truth of the matter is that doesn't quite work, and we unfortunately have to rely on others to define quality of care for us and hold us accountable. So until we can do it well ourselves and demonstrate it well to those that receive our care and pay for our care, we will be under the influence of those developing quality measures and accountabilities, and quite frankly, I think we should be doing that in spades. We're seeing massive provider consolidations or affiliations, maybe in great part due to those first two pressures. We're finding that the cottage industry of U.S. healthcare is increasingly unable to deal with the economics of scale that are required to deliver on some of the infrastructure and processes that respond to those first two bullets. And lastly, what I'd really like to talk about today, of course, is an increasing recognition that physicians need to play an integral part in this transformation that's happening in U.S. healthcare. Our goal, I believe, for most of us, is to move to an era in which the continuum of care is managed in a uniform and consistent way. And I think most of us might call that clinically integrated networks. So let me just kind of digress for just a quick moment to say what I consider a clinically integrated network. And again, thinking on the clinical, thinking on the integrated as kind of the key components as opposed to affiliation status or ownership status or some other kind of governance. First, to provide seamless care, we need clinical data sharing in real time, and that needs to happen. And then once the data is shared, we need standardized clinical protocols. Care should vary. It should vary based on the patient or his or her personal experience or his or her personal desires. But it shouldn't vary based on the physician or the nurse or the time of day or the hospital. We should have consistent clinical performance measures and reporting across our systems. And as we develop those systems, we should have clear team member responsibilities across multiple sites of care and a sense of camaraderie among disparate organizations. Even if I'm located in Little Falls, Minnesota, and I'm working with the physicians in St. Cloud, Minnesota, 40 miles away, we should have clear guidelines for what I do, what they do. And then we should have a sense of camaraderie among those. And lastly, kind of the ultimate goal is that our incentives are aligned in such that we're all moving in a single direction towards regional population health improvement. So that's what it should look like. And I think most of us would agree that doesn't happen very often, if at all. But if we're going to get to that future that I think will serve our rural communities best, our rural patients best, I believe that we're going to have physicians integrally involved in that process. So let me talk a little bit about physicians. So from Kim's background, you guys can probably guess my age, and I'm in my late 50s, so I've been doing this for a while. But many physicians in practice today implicitly believe, if not explicitly say, that they are autonomous, independent, and in control. And I said that at a meeting, I don't know, several months or a couple of years ago, and a medical director kind of in the back of the room said, "Damn straight." Now he was kind of yanking my chain, but still the point is that physicians are inculcated, socialized, and then later inculcated into this kind of sense of autonomy and protection and control. And indeed, when I went into private practice, I was left alone, and for better or for worse. And unless I really mucked things up terribly, I had a job for life. I was protected, and I had control over my day, over my life, my professional life, who I saw, etc. Now, I'd like you to contrast that to what's happening now. These are now the new imperatives that are being asked of physicians. We don't need to read them all, but the key here is to contrast this list, patient safety, quality improvement, patient satisfaction, with the prior one. And even get this one. We're being asked to recruit our competition. And here we are, the autonomous professionals. We're being asked to work in teams, for crying out loud. What's that? And and by the way, as I'll mention later, physicians are pretty good at working one-on-one with individuals, but we don't do so so well talking to crowds. So what is this that you're asking me to talk to my community? What is this? So these are all new imperatives. Now, we need to understand this shift from the yesterday's promises to today's imperatives. Because whether we like it or not, we will be moving forward as healthcare leaders in negotiations with physicians. And these physician negotiations can get contentious sometimes. So if we want to avoid these kind of situations, like you see on the screen, we're going to need kind of a new game plan. We're going to need a new game plan. So let me start off with kind of discussing kind of these relationships. You all may know Oliver Hazard Perry, or you may not. That's okay. He was famous for his naval battle in Lake Erie in the War of 1812. And he said famously, "We have met the enemy and they are ours." Now, I'd like you to contrast that to the great American philosopher Walt Kelly, who wrote about the swamp possum Pogo in the cartoon strip. And Pogo says, "We have met the enemy and he is us." So let me give you some examples. Now, before I do this, please bear with me. This is a little bit salty. For those of you who have sensitive ears, please mute. So these are exact quotes, verbatim quotes from CEOs that I have spoken to, hospital CEOs I've spoken to over the years. This job would be a hell of a lot easier if it weren't for those damn physicians. Speaking about physicians, they've got pediatric personalities. Or how about this? I'm going to drive that SOB out of town. And my favorite of all, from kind of a upper class New England community, CEO says to me, "Clint, the medical staff meeting will be held down at the local hotel. We don't want to get blood on our conference room walls." Now, so think about this for just a second. Think about how this is being said to this outside consultant from Minnesota. So think how that kind of plays locally in an environment in which we really want to work positively with physicians. And I like to contrast that to a friend of mine who was a CEO in northern Minnesota. And Jeff Stampahar said to me, "Clint, I'm blessed by my physicians." And, to be honest with you, folks, I don't care if he's lying to me. The point is that he's setting up a behavior that's positive for relationship development. Now, admittedly, that relationship development can be challenging. And I'd like to show you something that I adapted from the Dual Role Dilemma by Michael Kurtz, which I think is really fascinating. Now, as I talk about this, I'd like you to bear with me. That is, every time you talk about a physician or a administrator, you are automatically stereotyping, and that prejudice is automatically unfair. Now, that said, as I said, I want you to bear with me. That said, there may be lessons to learn, just like maybe some of you have done Myers-Briggs testing in your leadership teams, that help us, if we can understand the personalities of those that we are working with, knowing full well that there isn't right or wrong answers here, there's just different. And as my dad, who is a very wise man, said, "Clint, different is not wrong." And that's in spades here. But understanding some stereotypical differences may be important. And you might want to save this slide as you move forward working with physicians. Let me pick out just a couple to talk about. I've already mentioned the one-on-one interaction. That's what physicians do best. They work one-on-one with patients on a regular basis. They're not as comfortable working one-to-N to big crowds as an administrator might do. Physicians are decision makers. A physician in private practice will understand a problem, design a solution, and implement in 10 minutes, in 10 minutes in, 10 minutes out, 10 minutes in, 10 minutes out, all day, every day. Now, a smart, savvy administrator knows you can't do that. You can't, one, you just can't do it. It doesn't work. And number two, you'll alienate all of your team. So you tend to delegate that. Similarly, physicians are autonomous. That's the way we're trained to do. Let me give you an example, which just as I think back on it is really frightening. So I was a resident, early young resident in my training, and at 3 o'clock in the morning I had a particularly tough case. And I kind of bumbled through it. The patient didn't die, thank goodness. And at 7 o'clock during rounds, the 4 hours later, the attending said to me, "Clint, good job. You didn't even have to call me." Now, as a 24-year-old kid, I think, wherever I was at that age, I probably puffed out my chest and felt pretty good about myself. But think about that. Does that really make sense? Is that really what you want your healthcare providers to be? No, we really don't. Professional identification versus organizational identification. Take a moment sometime to pay attention to what happens at your next cocktail party. Hi, I'm Jane Smith. I'm a family physician. Hi, I'm Susan Moore. I'm ABC Hospital CEO. Did you see the difference? It's really critical. Physicians identify primarily with their profession, while administrators and leaders will often identify with their organization. So when the organization asks a physician to do something in the benefit of the organization, that's a leap. That's a leap. And it's important that we understand that as we ask physicians to be more participatory in our work. So it's obvious, based on this kind of difference in personality types and personality foci, that we can lead to differing views. And let me give you some examples from the advisory board. So this is an administrator view. I'm concerned about quality of care. Those docs are only concerned about their income. Have you ever heard that? Or have you ever thought that? Maybe. And physician's view. I'm concerned about quality of care, but that administration is only concerned about money. And boy, have I heard that one. So obviously, even though they're almost the same words, we're talking around one another. So there's no shared vision. And that no shared vision, unfortunately, leads to mistrust. And those of you who have been in administration more than about just a few months understand that it takes many occasions of trustful relationships, trustful experiences to outbalance that one episode which trust was broken. So administrators know one of their most important jobs is maintaining trust among their organization and, in this particular case for this topic, with the physicians that they work with. So what happens if that doesn't happen? Well, there's some pretty real consequences of this. Physicians can set up office labs, imaging suites, et cetera, and to be quite frank with you, they can compete with you as a hospital very successfully, as a matter of fact. They direct patients, they direct where resources are going to be spent, and they can compete quite effectively. And then, in response, the hospital can set up an urgent care clinic. So they can pull that primary care right out of that physician's office if they so choose. So mistrust increases competition. Duplication increases costs. And much more important for our venues, it decreases community confidence. Believe me, your community can see it. They can feel it when the when the physician groups and the hospital are at loggerheads. They understand it, and how do they respond? They outmigrate, which is just the opposite, of course, of what we need in our rural communities. So to get back to the physicians themselves, so here I am having a beer with John Sheehan. Now, John, some of you may know John. He's recently retired, darn it all. He was a rural accountant from BKD. So John and I are having a beer, doing it as doctors and hospital accountants sometimes do. We are talking about rural hospital CEOs. And John says, kind of out of the blue, the hospital CEO's most important job is developing and nurturing good medical staff relationships. And my jaw dropped open. I said, John, what? You're a numbers guy. You're not this kind of namby-pamby, hold hands in a circle and sing kumbaya kind of stuff. And John said, oh, no, Clint, this is all about money. What I do in accounting, I can improve the performance of a hospital kind of around its edges. It's the providers with their pens that direct about 85% of the resources. So if I really want hospitals to be successful, they got to be working positively with the folks that are using their resources. And I said, oh, now I get it. So what I thought from there is that maybe what we're really talking about is a cultural issue in an organization. Now, I got to pause for just a second when I talk about culture, because I have heard it, and you have all heard it 100 times. We've got to change culture. Well, what does that mean? So a culture of what to a culture of what? So we need to change culture is a meaningless statement. So it needs to be put in context of from where to where. So culture, though, is, I'm going to describe here, as a hidden yet unifying theme that provides meaning, direction, and mobilization. What I really like is a quote by Edgar Schein. Edgar Schein is the grandfather of kind of organizational psychology, and he said, culture is the residue of success. Isn't that elegant? Isn't that beautiful? What it's saying is culture is what drove the prior success, the residue of success. I think if we were to sit Dr. Schein down, he would say, in no way does that guarantee future success. So let me offer a little bit different definition of culture, and this is from MindNoodle, so you can take it or leave it. But I believe culture is what we do, our behaviors, and what we believe. And one will lead to the other. This is based a little bit in the science of cognitive behavioral therapy, that what we do, our behaviors, tends to lead to belief systems. What we do, what we believe is our culture. And I'm going to argue in this webinar that culture is measurable. It's measurable, at least as we talk about physician engagement as a cultural manifestation in an organization. And the reason why measurable is important is that measurement, as all of you know in quality improvement, measurement focuses attention. And one of the most important concepts in leadership, at least that I try to teach to the students at University of Iowa, is that attention is the currency of leadership. Let me give you an example. If the hospital CEO walks through my emergency department this afternoon and says, Clint, you're doing a really good job here in the emergency room. Thank you very, very much. And the folks that are working with you are really awesome as well, too. But you know what? We look at ED metrics in our board meetings on a regular basis, and we're noticing that time in the emergency department is creeping up a little bit. Would you and your colleagues take a look at that for me and see if we can find some ways to improve it? And we'll look at that metric again at the next quarterly board meeting. And if the next day the board chair wanders through and says, Clint, hey, I understand you're doing a really good job. My neighbors say that they're treated really well here. But, you know, in our board meetings, we pay attention to emergency department metrics, and I'm noticing, and so is the board, that the time in the department is creeping up. Would you and your team take a peek at that for me? We really want to provide good care to our community. Do you think I'm going to pay attention? Darn right I am. Leadership is attention is the currency of leadership. I'm going to attend to it because my bosses are attending to it. So my last bullet here is that physician engagement is a manifestation of culture. So let me talk about physician engagement in a definitional way for just a second. So I'm defining physician engagement, and I put a little asterisk here, or provider. Let me digress for just a moment and talk about that. In many of your organizations, non-physician providers may play a very important clinical role, if not leadership role. And I mean physician assistants, advanced registered nurse practitioners, etc. Most of the literature around physician engagement uses the word physician. That's probably because a lot of the literature wasn't done in rural America, where other providers are playing critical roles. So bear with me. I'm using kind of the monikers that's used in the literature more, but when I talk about physician engagement, I'm also talking about other clinical leaders as well too. So proactive, this is the definition. Proactive physician involvement and meaningful physician influence that move the organization toward a shared vision and a successful future. That's my definition. Proactive physician involvement, meaningful physician influence that move the organization toward a shared vision and a successful future. Now, although this is a cultural phenomenon, I believe that physician engagement is also observable, measurable, and improvable. So, how are we going to go about doing that? First, it requires mindful action. I do not believe that physician engagement in its best form happens simply by accident. And like other strategic moves, we really need a detailed action plan around it. And you all may have your own system for developing action plans, but I believe that there must be at least 4 components, if not more. That means we need a measurement, an objective measurement. We need single person accountabilities, and quite frankly, this is generally the CEO. And if you're, as a CEO, delegating the role of physician engagement to someone else, I think we have a problem in the organization. This is a CEO job. Resources need to be devoted to this. Now, resources is generally time. It's time, especially in this particular case, but it's time. Some of you have heard about management by walking around. I worked in Oregon with a very progressive CEO who knew that he had a meeting with me, but he said, Clint, I do have to tell you we're going to be cutting our meeting short from 1 hour to 45 minutes at this time every week. I make it a purpose of rounding through the hospital, talking to physicians, talking with the staff. That was his priority, and he devoted his time to make sure that happened. And then timeline and due dates. Now, I did bold in this next bullet is to be realistic. Relationship development, physician engagement is not easy. There will be times of great relief, and there will be times of great frustration. But this is really, really important work, and hopefully with this webinar, you'll be energized to go out and continue to work and persevere. Be courageous and persevere through admittedly tough strategic activity. Now, I said it was measurable, and I'm going to offer here in a moment some details around some measures that I think could help you if you're interested in looking at how your organization engages physicians objectively. And those measures are around governance, education, compensation, and data. Now, I put relationships in italics here, kind of wondering if they're measurable, and maybe I almost want to say trust. So, but when we see the manifestation of positive relationships, I think we see that in mutual trust. So you all will have to help me decide if relationships are kind of a measurable activity of physician engagement. So let's talk about those kind of strategies for success. And I'll detail each of these with some specific suggestions for you in just a moment. But we want to monitor your progress, and that's where I'm going to talk about the measurements. Finding mutual interest, nurturing leadership, communicating up and down. And I want to talk about that a bit. And if you haven't read the book, The Essential Drucker, it's a must-read for managers. It's all common sense, and it's all not used regularly, I think, at least in the worlds I've been in it. So communicating up and down, and then managing meetings properly. So let me talk about each of these in a little bit more detail. Now, please, I apologize for this slide. I didn't know how to do this really any other way. But I've worked on a kind of metric for measuring physician engagement in those 4 categories that I described before, and I call them domains. And you'll see those along the left border of this particular table: domain of governance, compensation, education, and data. And we really don't have the time to go through each one of these, but you'll see an activity, and then you'll see examples of where an organization can be beginning, progressing, intermediate, or advanced in the particular activity of, say, governance, board participation. That's physician participation on the boards, or provider participation. We won't go through all those, but please understand that the domains of physician engagement are observable, measurable, and I've listed the ones that I think may be important along these left border: governance, compensation, education, and data. You may have others. That's okay. But the key is here is that we are keeping track of our work in physician engagement improvement. Next, mutual interest. From the next few slides, what I'm going to actually suggest is some very specific activities that you can almost check off as you kind of move through your physician engagement journey, which will be ongoing. Is one of the, as you understand as leaders, developing a shared vision and communicating that vision with clarity and with consistency is absolutely important. That's very important with physicians as well, too. Their vision may be somewhat different than yours, and you need to understand, again, those differences in personality and priorities as you develop that. But agreeing and spending time and energy on developing a shared vision is absolutely critical. That second bullet is also very critical, keeping the hidden agendas out. You know, physicians are pretty insightful characters. They'll sniff out hidden agendas, and you will destroy trust pretty fast with that. Similarly, in that third bullet, solicit meaningful physician input early and often and act upon it. I'll tell you, I've sure seen situations where physicians are invited into a discussion after the decision has been made. And that is unfortunately a terrible mistake that happens quite frequently. Again, they will sniff that out, and they're like elephants. They just never forget. And so if you destroy trust by doing so, or do so with hidden agendas, it will be much, much harder to develop the positive relationships that we know we're all working for. Next, help them balance the priorities of business and patient. They are not trained in running organizations or financially managing organizations. Their world is patient care. But they're also generally smart people, and sometimes they're business people as well, too. So you'll need to work with them to help them understand that your job is balancing different priorities and negotiating different priorities. That's exactly what a leader does. In fact, that's probably his or her main job, is exactly that. This is almost never in our world either or. It's and. It's and. So that's how we have to kind of think about this. And then as you do those shared vision and you set your goals, set them realistically so we have some celebrations and, of course, some wins and celebrate those. So that's mutual interest. Next is physician leadership. Again, medical school generally does not train us to be either leaders or to run complex organizations. So we need some background in that. And I believe that if an organization, a healthcare organization, is interested in maintaining physician leadership, they need to do so by identifying, mentoring, and educating physician leaders. And this is an investment. This is an investment. And I think it's an investment that will pay off for you in spades. Similarly, reward physicians in ways that they value. The reward is not always compensation. That isn't always kind of what we're looking for. But instead, think about the ways that you reward employees that are not compensation. So do be thinking about rewarding in ways that they value. For me, in my life, what's really of value is time management. So, for example, a hospital administrator who seeks me out to find out the time that it's best to meet, and also only holds meetings when it's appropriate, I think is the one that I'm going to resonate with much more. Similarly, you can attend a leadership conference together, and that kind of flows into getting to know physicians on a personal level, meeting one-on-one. I really like the idea. Now, it depends a bit on your medical staff size, but I like the idea of either informally or a little bit more formally, like a lunch date, visit with a physician and ask her, in essence, kind of what's annoying you these days? What are the things that are kind of making your job more difficult? How could I be helpful to you in that way? Or what are you seeing in processes in this hospital that are not facilitating good patient care or safe patient care? How can I help in that? And you're not even coming to the meeting with an agenda, but it's simply that, and it would turn into a really important fact-finding for you. And that's where I talked about communicating up and down. Now, Peter Drucker said that in times of change, efforts at communication should be tripled in an organization. Well, like, duh, and are we in a era of change in healthcare? Absolutely. So I think when we consider change or communication, we tend to think of, well, we got to do memos and we got to do emails and we got to do meetings and group meetings and things like that. I need to tell everybody what's going on, and that's true. You need to be transparent. I worked with a hospital in Indiana, and boy, almost every person I talked to when I talked about the culture of the organization, using not those words, I heard the word transparency. It was really a profound and consistent theme that I heard. So yes, you need to be transparent and you need to communicate down on a regular basis. But communicating up is listening, and it's active listening, and it's respectful listening. And that needs to be done in an intentional way, Saying my office door is always open is not intentional. So we need to be more aggressive about intentional listening. That's communicating up and down. Here's the communication. Ask how, when, and where, multiple meetings, multiple times. And I already described before that hospital CEO that I worked with out in Oregon who left the meeting with me to simply get out and about. We call it management by walking around. Now, I mentioned that your jobs are often, if not almost exclusively, negotiation. Yep, that's what it is. And one of the keys to negotiation is developing those shared visions which can turn into shared interests. If nobody's going to argue about the importance of patient safety, nobody's going to argue about the importance of improved clinical quality. Now, we may argue about the metric. We may argue about the resources that it takes to get there, but those are positions. Our interest is that our patients are cared for with high quality and with safety. So we want to focus on those interests. And if you all haven't read the book, it's sure absolutely worth a read. And it's an old one. It's called Getting to Yes by Uri and Fisher. And just an interesting tidbit about that, you may know the name Elliot Fisher. Elliot Fisher is the Dartmouth researcher and physician who has done a lot of work on healthcare system change. He's done a lot of work on accountable care organizations. In fact, it was he who actually came up with the name Accountable Care Organizations. And in a conversation I had with him a couple of years ago, he didn't really like the name very much, but nonetheless, it is he. Turns out his dad is Fisher, the Fisher of this book. So pick up Getting to Yes if you haven't. It's really important as you move into the negotiations of your world. I mentioned this data transparency when we communicate. That's important, but it's also important not to overstate discrete measures. Physicians don't tend to think as much about a single metric as the way to judge the quality of care that they are providing. So we need to balance our need for objectivity in our measurement with the realization that healthcare is not sound bites. And that's a tough one. And I think if you but if you acknowledge that reality on a regular basis and ask for feedback about what metrics that are measurable, obtainable, but also valid, meaning they measure what's important. I think that you'll be in more positive stead with your physicians as you present your performance data. So data transparency, but not overstating the discrete measures. Meetings. So if you talk to a physician, most physicians, they hate meetings. They hate meetings. Why? Nothing gets done. No patient gets cared for. Plus, get this, I don't get paid. So everybody seems to hate meetings. You know, now, yes, all of us have probably been in organizations in which the staff seem to have a planning meeting to be able to get to the meeting. Well, we do need to kind of plan the purpose of our meetings and make sure that we really do need to take time from people's schedules to be able to do so. So as we're planning our meetings, invite physician input early. I mentioned the problem previously with inviting physicians to provide opinions when a decision has already been made. That's a pretty bad strategy that will certainly come back to bite you, in my opinion. We really do want physicians involved in strategic and capital planning, and you need to kind of help them understand the importance of their input as you try to make decisions about your organization, a healthcare organization, moving forward. Schedule meetings and select venues appropriately. It seems at times hospitals want to get up and moving on a Monday morning, get everybody kind of energized, and set the pattern for the week about what projects we're going to work on, how we're going to get our work done. And if you ask physicians to participate in arguably the very busiest half day of their week, Monday morning, it just really doesn't make sense. So we need to be thinking about who you want to participate in the meeting rather than simply setting up meetings as you've always done. And so I talked about scheduling the meetings and selecting the venues appropriately. Present actionable information. Oh boy, if you've been guilty, probably like I was a few slides ago, just presenting a table or a little bitty font or a spreadsheet, God forbid, on a PowerPoint, please stop. Here's the goal. If you're presenting information to physicians, and you know what, it probably isn't just physicians. It's probably your entire team or your staff. Present information in a graphic that they can understand within about 10 seconds. 10 seconds. And then 10 seconds later for a physician, I'd like her to be thinking about how can she change her practice this afternoon to make that data or that information more favorable. Present actionable information, not data. Now, everybody there always will be someone in the crowd that says, I don't believe you. That the data is wrong. Well, you know, it might be easiest to just acknowledge right up front that no data are perfect. There's no such thing as perfect data. And you're always interested in ways that we can make the data more accurate and kind of in the parlance of a statistician, more reliable, more repeatable, more valid, more important. So ask for that, provide that caveat right up front, that disclaimer, nothing's perfect here. Always ask for feedback about how to make it better and agree to work on that, to do that better. And then if you can't show the details of your chart kind of on the chart because it'll be too messy, keep that spreadsheet in your back pocket. So when someone does say, I don't believe you or the data is wrong, we'll say, oh, let's sit down together and I'll show you exactly how that chart was developed. And if there's a better way to do this, let me know and we will do it together. As you leave the meeting, delineate next steps. And oh, please, 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 always follow up as promised. Once again, those dang physicians, they're like elephants. They will remember. And if you explicitly or even implicitly promise a follow-up or something you're going to do in the future and it doesn't happen or they don't hear that it happened, once again, it's an opportunity for mistrust. So that's one of those things that you need to keep your to-do list active, and it may be one of those, did I follow up regarding issue ABC with Dr. B, ? Monday? Yeah, do that. Always follow up as promised. Then there won't be any miscommunication. Let me kind of quickly, as I wrap up here, and we're just about done, kind of tell you a little bit about the Rural Health Value Project. Now, this is a project that I am working on at the University of Iowa, and we're in partnership with Stratus Health. What used in old parlance, the Quality Improvement Organization in Minnesota, that isn't the words we use anymore, we call Quality Improvement Networks. But nonetheless, Stratus Health is the quality improvement experts, especially for Medicare and many other payers and patients in Minnesota. And they and we have a Federal Office of Rural Health Policy grant, and we're very, very thankful for the office's support to do this. And please take a look at ruralhealthvalue.org, and you'll see there tools and resources and profiles and guides, white papers, articles that will be helping rural healthcare organizations and rural communities move from our current world of volume-based payment and volume-based care to one of value-based payment and value-based care. And I'd argue to make this absolutely tectonic transformation in healthcare, and it's happening slowly but consistently, we must have physicians on board to help navigate that transformation. And I think you may find some resources at ruralhealthvalue.org that'll kind of help do that for you. Just to kind of tell you what's up right now, just yesterday, I launched on a webinar our value-based care strategic planning tool. So if you have a chance, take a look at that. And the kind of rationale behind that is if we are moving into a value-based payment world of accountable care organizations and bundled payments and care coordination payments and payments to patient-centered medical homes, then to be able to access that payment, we have to deliver value-based health care. So what this tool does is it assesses 121 value-based care capacities, the capacities of a healthcare organization to actually deliver value-based care in 8 different categories. And what we found is, with beta testing this tool, that it's very effective for educating boards, leadership, other key stakeholders about this volume to value transformation. It's also very helpful, hence the title, in strategic action planning. We also, I hope this upcoming month, will have available to an Excel-based critical access hospital fee-for-service cost-based reimbursement financial pro forma. Now, you hear about all these new kind of types of payments coming down the road, ACOs, bundled payments, care coordination. Have you wondered what would happen if everything just stayed the same? If I simply close my eyes to all that cacophony of new payment and I settled into negotiating contracts for fee-for-service with my commercial payers and getting cost-based reimbursement from Medicare. And who knows about Medicaid, depends on your state. But nonetheless, if I just did everything the same, what would happen financially to my hospital in the next 5 or 6 years? I think it's an important question. And this pro forma will help you do that. So if you're interested in that, we hope to have that up and launched here in this month. It's an Excel spreadsheet. It's free to all, as is the value-based care strategic planning tool. It's free, available to you. Next, similar talking about payment, you may say, no, wait a minute. I don't like the way my finances look, just sticking with cost-based reimbursement going forward 5 or 6 years. I want to get in on the action of value-based payment, but I don't know how to assess a contract for an ACO or a bundled payment. So we're working with Premier, Inc. In hopes of developing, again, admittedly more complex Excel spreadsheet-based pro forma tool for you to help analyze those types of contracts. I wrote late 2015 here. It may be a little bit later than that. Could be early 2016, but that's certainly on our plate. And there's lots more. So we'll be continuing to update that. We're very fortunate in a competitive process to have a renewal of our 3-year contract with our friends at the Federal Office of Rural Health Policy. I am very excited to work with those professionals and with Stratus Health, and I hope you'll see some really good information on our website, ruralhealthvalue.org. Here's a few more resources for you regarding physician engagement. There are lots, so take a look. If you'd like more information, take a look. Here's some of the resources I've used, and there are probably many more. To wrap up and to conclude, I want to believe that physicians can be astonishing allies. They can be really helpful as you move your healthcare organization forward. But that particular allied movement starts and ends with relationships built on trust. It's trust that engages the mind. It's truth that engages the heart, and it's our teamwork, working together, physicians and administrators together, side by side in a shared vision that realizes where we want to go in this new healthcare world. Thanks very much for listening to me. I'd be happy to take some questions over the next few minutes.
Clint, thank you so much. That was an excellent presentation. If anyone has any questions for Dr. McKinney, please press *2 to unmute your line, or you may type it in the chat box on the screen. Dr. McKinney, here's a question. How do I address board members' concern about undue physician influence in hospital governance?
Oh, thanks very much, Kim. That is an important question. In my suggestions for engagement, governance is one of them, and board participation is one. I think if you read most of the writers currently about physician engagement, virtually all, not all, but virtually all, will be recommending that physicians serve as board members where state